Welcome to AETCM. Today I'll be presenting a case of 65-year-old male who presented with complaints of headache and vomiting since last 10 days. On 10-second assessment, patient was conscious, oriented and obeying commands. On airway was patent, there was no secretion, gurgling or pooling of saliva. Breathing, patient had a respiratory rate of 16 per minute with a saturation of 98% at room air. On circulation, patient had a BP of 130/60 mmHg with a pulse rate of 46 per minute. On disability, patient had a GCS of 15 out of 15. Pupils were equal and reactive to light. Patient had a pain score 9 out of 10, and at this point of time 2 IV cannulas were put, and then we had given one injection PCM 1 gram IV stat. On exposure, patient was febrile, and on GRBS, patient had a GRBS of 110 milligram per deciliter.
What was the mechanism of injury?
Patient didn't have any injury. Patient just came with history of complaint of headache and vomiting since last 10 days.
That's it. Just simple headache and vomiting. Okay. Headache and vomiting and disability pupils?
Pupils were equal and reactive.
No. But he has a 9/10 pain. So now the question, 1 week history. 1 week or 10 days? 10 days history. So 10 days history, headache and vomiting. Okay. Continue.
Coming to the adjuncts of the primary survey, at this point of time we had done a CBC CRP just to rule out whether there is any infective pathology.
No fever, right?
No fever was there.
And again, 2 large bore IV access was never indicated in this patient. He is not having any hypotension or anything. A single IV access would have been enough. So we never would have put a 2 bore IV access. For the sake of presentation, you are telling 2 large bore IV access. Okay, it would have been a single IV access only we would have secured. And again, it is a non-trauma patient. You don't have a history. It is a cooked up history. So that's okay. The next one, sample history. Continue.
Coming to the sample history, 65-year-old male who is a known case of CAD, double vessel disease, status post CABG, also mitral valve repair, known case of diabetes and dyslipidemia, presented with complaints of severe headache since last 10 days.
Okay.
Headache was over the frontal region and it was more on the left side. Okay. It was of acute onset and gradually progressive in nature.
Okay.
Patient was evaluated at 2 outside hospitals where he was given multiple analgesics. Okay. On taking the analgesics, pain subsided to a lower pain score, but again reappeared. Okay. And on the day of the presentation to our ER, patient had 5 episodes of vomiting. Okay. That is why patient came at the night time to our ER. Vomiting was non-projectile and vomitus was fluid in nature. There was no history of any fever, seizure episodes. There is no history of any limb weakness, no history of any trauma, drowsiness, no history of any diplopia or vision abnormalities.
Okay. Okay.
On general, coming to the general
drug history.
Drug history, patient was taking warfarin since last 3 years.
Sample history, I think you have to tell regarding medications, no?
Allergic. Allergic.
You went to general examination in between. Tell. Continue.
Allergic history. Patient didn't have any history of any allergy to the drugs. Then coming to the medication history, patient was on taking warfarin 5 mg HS since last 3 years. Then patient was also on Ecosprin 75 mg OD since last 3 years. Coming to the past history, patient has a history of CAD, double vessel disease, status post CABG. Patient has also done an MV repair. Patient has been known case of type 2 diabetes mellitus.
MV mitral valve repair or replacement?
Repair.
Okay.
Patient is a known case of type 2 diabetes mellitus since last 10 years.
Okay.
And also a history of dyslipidemia is there.
So why he is on warfarin?
It was MV repair was done and it was started.
Mitral valve replacement, mitral valve repair. So we have to see what are the indications for warfarin for a mitral valve repair. What exactly the repair was done? It is almost done very long back, no?
Yes, 2017 it was done.
Okay, so they still maybe initially they would have thought of a mitral valve repair as such requiring warfarin. What is the indication? Mitral valve replacement we can understand. We can have a stuck valve if it is an old school of valve that has been kept. But when bioprosthetic valve, we don't need. But why the patient is on one anticoagulant and an antiplatelet agent? CABG we can agree, one ecosprin we can accept, but anticoagulation with ecosprin combination justification is not. Mitral valve repair, maybe the initial phase we can consider, but there is any history of atrial fibrillation. That was what he was in sinus rhythm only, no atrial fibrillation. So whether that warfarin was really needed is my question here. So how will you decide who needs a warfarin, who doesn't needs a warfarin? How will you fix up that?
In case of any valve replacement.
Okay. So where you usually start a patient on warfarin? As you said, valve replacement. In an ED perspective, where all you will start warfarin? Which all group of patients? Okay, this patient we should start warfarin. Where all you will start? Not an ED, maybe after 48 hours. Emergency room as such, we need not do because we have parenteral agents like heparin is available. We have low molecular weight heparin available. But where after maybe 48 hours, definitely in a atrial fibrillation, chronic atrial fibrillation, we can't give him continuously on heparin, so you need to change on it. And a DVT, you have treated DVT or pulmonary embolism, you have treated, now you need to switch over to another agent. So usually that it will take like 5 to 7 days, that bridging therapy. So maybe in the second day or third day itself, we need to start warfarin. Then only it will start slowly building up. By 1 week time, the targeted INR will reach. Similarly, for a prosthetic valve. Now there are a lot of bioprosthetic valve which actually doesn't require warfarin therapy for beyond 6 months. So like this question that comes around in my mind, how will you decide? You have to calculate the risk versus benefit. You have to put the risk versus benefit. That are the scoring system that is available for atrial fibrillation. Do you know the name of the scoring system? It is the CHAD-VAS2 score and has blood criteria. CHAD-VAS2 to what is the risk of thrombosis or any events that is going to happen, and we need to put this side what is the bleeding risk for this patient. So depending upon these two groups, we need to decide, okay, whether this patient require a dual, just an aspirin is enough, or he doesn't need any of the antiplatelet or an anticoagulant agent, or he needs a combination of anticoagulation and antiplatelet, which is doublet, so which is pretty high. Even single warfarin itself is a big thing, but on top of that, you are giving a heparin. You are not giving. I'm telling you, someone has prescribed him warfarin. Maybe he would have lost follow-up. You're saying this happened in 2017, and now we are in 2024. Maybe 2017 he was only less than 60 years of age. Maybe the chance of bleeding would have been less. So somebody would not have reviewed him appropriately, and after maybe after he crosses the age of 60, whether that bleeding risk has not been started. So I'm not saying this patient had bled, but from the history we know that what has happened to this patient. So that is the reason why I'm pinpointing and asking warfarin. And again, if the patient is not on warfarin, you are seeing a lot of newer agents, rivaroxaban, endoxaban, all those things are also there. So again, you need to definitely think over when you are starting this group of drugs, risk versus benefit, what is the exact mechanism, how they will act, and what are the risk of an ischemic event if the patient is not on this drug. So depending upon that you need to decide upon. Okay, so ecosprin and warfarin. Okay, then
That was the medication history, past history of CAD.
So how frequently, what was his last INR?
Last INR was, patient was asked to keep on an INR level between 2 to 3, but patient was not on regular monitoring.
Okay. So what are the problems that can happen when a patient is on warfarin? What are the issues a patient is on warfarin? What advice that you will give? Okay, you're discharging a patient from your ICU or from your ER who is on warfarin. So what advice you wanted to give him on warfarin?
Monitoring of INR.
Monitoring of INR, and you need to tell him what are the target INR that is required. So like it is 1.5 to 2 to 2.5. Usually 2 to 2.5 reasonable for all the conditions. Even atrial fibrillation, pulmonary embolism, all those things. Maybe some bioprosthetic, some valve, metallic valve maybe require a little bit on the higher side. Maybe 2.5 to 3 that is required. So usually 2 to 2.5 is a very safer zone, and that you need to tell him how frequently you need to check in, and what are the other advices that you will give. Any new drug that he is going to start. So when a doctor is planning to start him on any drug, the drug interactions are very key. And what are the diet advice that you will give him? He should be avoiding green leafy vegetables, spinach and all, which has got gross of interaction with warfarin. So whenever he is starting on a new drug, you need to There are some drug which decreases the potency of warfarin. There are certain drug which increases the potency of warfarin also. And he's on warfarin with ecosprin, the bleeding chance might be double or triple the time what he's on right now. So whenever they are starting a new drug, the doctor need to check in the interactions, what is going to happen. Sometimes you need not require that much dose of warfarin, or some diet changes that has happened, and that can cause an increasing the INR or decreasing the INR. It can go subtherapeutic and it can go above the therapeutic level also. So that information is what is very crucial in any group of patients that you are discharging from the ED. So drug interaction and what time they should, usually they will take it in the evening time. So what time they should be taking it and how frequently they should be checking the INR. Preferably, ideally, when you look in through, you need to check in ideally once in a month minimum, bare minimum. They should be checking the INR and should be monitoring and should be keeping it in the therapeutic range. So that information you need to collect. Okay. So warfarin and ecosprin. Anything else?
No, these were then for the sugars and dyslipidemia. He was taking the medication for. Only those medications was the regular medication. For sugars, he was taking human atrapid and NPH was going on.
Okay. Okay.
That was the regular medications.
Okay. Now you have done your sample, allergy, medication, past history, events that got him. He has got headache and he had in between vomiting also. So with this background, any history of trivial trauma or anything?
No.
So can we get, what are the trivial trauma that you say? Okay, this with this patient on a dual antiplatelet, what are the potential, any trauma we know that any fall we will definitely consider. What are the trivial trauma that the patient majority of the time get unnoticed?
During sleeping, dosing
Minor.
dosing off can be there.
Then going in the car, maybe suddenly it would have hit somewhere that we will not be remembering, and an event would have happened somewhere anyway between the last 1.5 months to 2 months. So the patient might not be aware of that. Like a spontaneous atraumatic bleed is unlikely, but some minimum trauma should be there from the background history. Okay, so what you have done for him now?
So initially, we had given analgesics, injection PCM, and then monitored the patient, and then we have reassessed the patient. So on reassessing also, the patient was complaining 8 out of 10 pain. So then we had, since the patient does not have any fever, infective markers were low, then we were suspecting any trauma. We had taken a proper history, but patient doesn't remember of any trauma.
Okay.
So then we were planning for getting an imaging done for the patient since pain was severe.
Okay, so let me ask you a question. When will you decide for an CT imaging for a patient when you are suspecting a trauma? We all know when you need to take in any low GCS on presentation, focal neurological deficit, seizure, base of skull fracture, immediately we need to get an CT. But this group of patients is a big dilemma, whether when to take, when not to take. Especially this patient, we have at least you have got risk factors. We have got like warfarin and all those things, not relieving by analgesics. But the other group of young patients that is coming to the ED, it's a big challenge for us. Young patient coming to the ED, it can be an acute migraine attack. So it can be very rarely a subarachnoid hemorrhage also. So from what all aspects, okay, you will decide, okay, this patient requires an brain imaging, bare minimum CT brain. How will you decide?
Acute sudden onset of pain.
So you should know the red flags. That's what I am asking you. Sudden onset of pain.
Pain not relieving with analgesics.
Pain not relieving with analgesics.
Pain associated with vomiting. Pain associated with other neurological features like any seizure episodes, any limb weaknesses. Then patient.
Then again. Any other focal deficits. We can just put focal deficit. So everything will cover under the focal deficit. Then. The worst headache in the lifetime. That is a classical history that you will get for your subarachnoid hemorrhage. They never had this sort of a headache in their past. So this is the worst headache. But majority of the time you will have a migraine overlap. So definitely neck stiffness, very important, significant. Neck stiffness you have to look in for. Again, subarachnoid hemorrhage can have neck segment. So you should know what are the red flags that you should be taking in. So the mostly this patient would have need an CT much earlier, that he is actually presenting very late. Maybe the initially itself it's not relieved by analgesic, considering his age and risk factor. So age and risk factor is the other thing. The patient is on an antiplatelet, the patient is on an anticoagulant agent. So it should have been a much earlier CT for this patient than a late CT. Okay, so we went ahead with a CT.
We had done a CT, and in the CT we had findings of acute SDH along the bilateral cerebral convexities, left more than right.
Okay, so I will not agree with the terminology acute SDH. It can be a subacute SDH. I'll say. Maybe acute SDH, it will be something less than 3 days duration. Subacute may be something like a 3 to 2 weeks time duration. You can call subacute. The patient had a symptom since last 10 days. So most likely it will be a subacute. So we have 3 or 4 types, I will say. You can have acute, subacute, then you have chronic, then you have acute on chronic. So it is not very mandatory for us to differentiate these things, but as a treatment aspect, definitely yes, they will need to do. So as an ED physician, how will you differentiate between an acute, subacute, chronic, or acute on chronic?
In the imaging, we can do in T1 and T2 flare. We have to see if it is
T1 and T2 flare you didn't do, no. You did a CT only, no. From CT, I am asking you, how will you differentiate?
acute. We can see as hyperintensity,
So
area.
that is again subjective, no. Your hyperintensity will not be hyperintensity for him. Your hyperdense will be not hyperdense for him. So the most important thing, that is something that when we learn the basics of CT imaging, is something called as Hornsfield unit, HU. Hornsfield unit is what you can use here. So just for the, you can to just see if it is like 50 to 60. If 50 to 60 is the HU that is coming up. When you are keeping the cursor there and in the blood area, it is coming HU is around 50-50. You can consider that it is probably an acute SDH. Somewhere it is like 30-35 and all. You can say that it is subacute. If it is much more less than that, it is already solidified, liquefied and all, you can call it as an chronic. Something, it might be something between 0 to 10. So it will be a chronic SDH. So that is a way by which radiologically we can differentiate between acute, chronic and subacute. So I am telling here from the history, I feel it is more of subacute. And you can argue, no sir, it is an acute one. So just how you confirmed it is an acute one. I checked the Hornsfield unit. The H unit is above 60, 50 to 65. Agreed. It is an acute SDH. So that is how you can differentiate. And there is a fourth category, that is the most difficult one, acute on chronic. Acute on chronic, you will have some darker area and you will have some hyperdense area. So there will be some demarcation. You will be seeing something like an pleural effusion sort of a thing inside the brain cavity. So there is a chronic component is there. On top of that, there is an acute component. So you will have hyperintense signals also, you will have the hypodense areas also. Both this thing you will be able to see. But HU, depending upon the area where you are keeping, the HU varies. Suppose you keep it in the chronic area, it will be very low. If you keep it in the acute area, it will be above 30. So that is how you have to differentiate acute, subacute, chronic and acute and subacute. So that is the easiest way. But in the problem that when you are getting a CT film, it might be difficult, but when you are using it in the PACS, that is the computer system, you can just go the cursor and keep it the cursor over the bleed, so the automatically the HU units will change, the Hornsfield unit will change. So if it is calcification, it will be very high. So that is how we have to differentiate whether it's a bleed, whether it is a calcification. To differentiate, use the HU. Okay, so you said it's an acute SDH. So let's see, we will go back and review the CT. Acute SDH involving
the bilateral cerebral convexity. So
okay.
Left more than right was there, with a maximum thickness of 17 mm on the left side and 12 mm on the right side. So there was a significant mass effect also in the adjacent sulcal spaces and the lateral ventricles, with a midline shift of 9 mm towards the right.
Okay, it's a bilateral SDH with a midline shift of 9 mm. So the midline shift is much more actually, because of the other side it has not shifted, because there is an SDH also pushing this side, and from this side there is also another pressure. Still there is 9 mm. So it's actually that patient should be taken for an craniotomy, but again we have challenges here. So when was the last dose of warfarin? When was the last dose of ecosprin? Everything we need to look in for. And majority of the time this SDH, no, you will not get any weakness. So that is the most important. You won't be getting any focal neurological deficit. Rarely they will be citing some upper limb weakness, lower limb weakness when that area is getting involved. Majority of the time you won't get any of this clinical. Maybe even altered sensorium, yes, you can get an altered sensorium, but weakness as such presentation is rare. But as you rightly said, without analgesia, you went ahead with the CT scan and you have picked up an subdural hematoma. So what is the pathophysiology of subdural hematoma?
It can be due to the breakage of the vessels. That is, mostly it will be vein pathology. Rarely it can be also in the arteries also, it can be there.
Okay. So mostly it is the dural cortical plexuses, the venous connection that is getting, because of the sharing force, age factor and all those things. The mostly traumatic. Some trauma history will be there, and because of this history of single antiplatelet with an anticoagulant, a trivial trauma itself can cause the bleed. So that would be the reason why he had developed this. Now you have diagnosed this. The patient is in front of you. So how will you proceed further?
Any patient diagnosed with stage, first we have to keep the patient in the 45-degree propped up position.
Okay.
Neck lines should be avoided for avoiding the pressures. Then the patient's GCS should be monitored. Preferably in first 6 hours, every half an hourly monitoring should be done, and up to 24 hours, every hourly monitoring should be done. Then patient's BP should be monitored. Hypotension is the biggest problem here. So we target a BP. If the age of the patient is from 50 to 69, BP should be more than 100, and above
systolic BP.
Systolic BP should be more than 100, and if the age is above 70, then it should be above 110. mmHg should be maintained. Then
this is more of a severe traumatic subdural hematoma, but this is situation is we don't have a clear history of trauma. Here he's been maintaining like this for last 10 days. The reason being he has a lot of space because of the brain atrophy, because of his age factor.
Then we should also keep normothermia should be maintained. Hypoxia should be avoided. A saturation.
My first thing what I'll do, I'll give him a vitamin K. That will be the first management that I wanted to do for him. On warfarin, some reason not very clear, there is a life-threatening bleed. Give vitamin K, which is easily available in your ED. And next thing, all those things I will do because it's already done in a systematic way, whatever I agree. But the priorities will be for this patient will be the reversal of warfarin. So that will be the first priority. Reversal of warfarin, first thing you have to give this. Then what will be the option?
4-5.
We don't have. We have.
No.
We actually have, but it's very costly. You need to ask. It is very costly, but life-threatening bleed we can definitely consider giving. Or what is easily available?
Vitamin K.
Then fresh frozen plasma. Ask for fresh frozen plasma. How much? 10 to 15 ml per kg. You give it and do the reversal immediately. Because I'll be very keen on doing the reversal much more faster. Because I'm not very much concerned about that mitral valve repair which has happened long back. If it's a stuck valve, if it's a bioprosthetic, not a bioprosthetic, the old metallic valve, then I'll be more concerned. Here, I know this is the one, but which doesn't require, maybe he would have lost follow-up in between, something not clearly monitoring INR. So I'll be very keen on to stop the effect of warfarin by giving the reversal agent. So that will be my priorities, one for this patient. ABCD, yes, but we should be doing the vitamin K and FFP arrangements. And aspirin, something can be done. When he has taken the last dose?
Previous day he
both warfarin and
he had not stopped the medication.
Okay, what was the INR on arrival?
INR was 2.3.
Only one investigation we need is INR. We don't need any other CBC, CRP. We just need one investigation.
1.03 it was.
That was after reversal.
After.
Okay, let it presume that it will be more than whatever be the requirement. It would have been on the higher side only, definitely. So, definitely you need reversal because this is a life-threatening bleed. So, that is a decision irrespective of the INR. Irrespective of the INR, where you want to give the reversal agent. Irrespective of the INR, you have to give reversal agent because he is on warfarin. So, you need to give vitamin K as well as FFP. And same patient, he not had any bleed. Okay. So, he is coming to you and because he has been lost follow-up, there is no bleed in the CT. But his INR, they are coming and tell it is NCD, no clot detected. So, what will you do? No clot detected. That definitely will do. No clot detected. That is his status and he is in front of you.
No symptoms.
But no symptoms. So withholding again, minor bleeding, major bleeding, there are criteria. So which is the life-threatening bleed? The area where we can't give any compression. So IC bleed, where we can't do. Intra-optic bleed, inside the eye, there is a bleed, where we can't do anything. So this area, it's equivalent to a life-threatening bleed. But there is an external bleeding where we can give a compression. So that group of patient, but here it is NCD. So if it is NCD, non-clot detectable, preferably you can give 1 dose of vitamin K. So there is no harm. For this patient I am telling you, because anyway it is on the higher side, so anytime he can have a spontaneous bleeding, so you have to reverse it. Suppose it is somewhere around 5 to 8, I would have done this. Maybe an oral vitamin K, we could have just waited for him. and the next we'll just wait. Next day we'll just check the INR. When it is less than 5, I'll plan to restart the INR. Restart the warfarin. Restart when it is less than 5. I'll plan to restart the warfarin. So that is the key thing that you need to differentiate. So with bleeding, any INR you need to give the reversal agent. So depending upon that, for each agent there are criteria. For giving your dabigatran there is a criteria. For giving your roxaban there is a criteria. For giving your heparin, what is your reversal agent that you want to use? Protamine sulfate. How much unit you want to give? So how much unit, depending upon the heparin that you are given, you have to calculate the dose of protamine sulfate. You can both for low molecular as well as you can give it for normal unfractionated heparin also. You can give the reversal agent. Both can be given, but it will be more effective for your unfractionated heparin. But low molecular heparin also you can give your protamine sulfate. Okay, so the reversal agent is the key. And next important thing, when to take up for the surgery. Definitely he needs surgery, there is no doubt. Burrow evaluation won't work here. He need to take in for craniotomy. What they have done?
Initially, they had done a burhole
evacuation. Why they have done a burhole evacuation? There could be a reason behind that. Because a craniotomy holds a higher risk for hemorrhage. A burhole evaluation on the maybe on the side where the maximum SDH, they would have gone ahead and done the burhole evaluation, because at least the midline shift can be avoided. But definitely there is a chance of rebleeding. So if the patient was otherwise stable, there is no midline shift. There is no mass effect or anything, they could have waited for another 3 to 4 days where the warfarin is reversed. We can easily reverse warfarin. The problem is with ecosprin. Ecosprin, we don't have any reversal agent. So it will take at least 4 to 5 days for that effect of ecosprin to stop. So they would have waited for another 4 to 5 days, and maybe they would have done a craniotomy or a burhole evacuation. So that is depending upon during that time. Bilateral involvement, how much area it is involved, that the surgeon will decide. But initially why they done a burhole maybe to immediately evacuate the blood, and later on what they did?
Later on, patient was in the ICU.
Okay.
Then following 48 hours, a CT was repeated.
Okay.
So there was again rebleed.
Okay.
So
Okay.
then they took the patient for craniotomy.
That's the answer. So we are expecting these things only, because why they did initially was to just buy some time, because that mass effect, pressure effect can be decreased. But because of the aspirin, whatever reversal agent you will give, for warfarin it will be corrected, but for this ecosprin there is a high chance of rebleeding. So that is very common with subdural hematoma. So they have a rebleeding, and they did for a decompressive craniotomy. Okay. Then he recovered completely.
Yes, he recovered completely.
He recovered completely. So what are the medications at time of discharge for him?
At the time of discharge, again they have started on Clexane 0.6 ml, they have continued. Then warfarin 5 mg again to be continued on HS basis. Then ecosprin also was continued.
Okay, so again that was the discharge medication. So definitely he would have had a reason. Still I don't know why the warfarin is being continued. I disagree with the reason being why the warfarin needed to be continued, unless and until we are missing some history. Something gross we are missing. Mitral valve repair, it not be just a mitral valve repair, there will be something else that would have happened. That is the reason why he was on an aspirin as well as an antiplatelet agent.
Sir, if it will be a metallic valve, warfarin is definitely required for the patient. But if the patient is also having like this IC bleed, so how to manage?
See, the problem is that metallic valve, definitely once the bleed, everything is stopped. You are very sure that there is no rebleeding. Then we need to restart warfarin. Otherwise, the valve will be a stuck valve. So it is a double-edged sword. To starting warfarin or to give heparin itself is a big challenge in this group of patients.
But should we reverse in the initial, like when the bleeding is active?
It's a life-threatening bleeding. It's a life. Definitely, we need to reverse. It's a life-threatening bleeding. If you are not reversing, he is going to die. So the stuck valve also he will die, but right now the problem is something else. He is bleeding right now, so reversal has to be done. So that is the life-threatening bleed. So that is the guidelines what you have to follow. Okay. Fine. So the take-home message will be what for this patient? So from this patient, what we have learnt?
Real injuries also should be identifiable.
Okay. The thing is that headache. What we actually discuss is headache, because we have picked up a subdural hematoma which he had for the last 10 days. So the most important thing, when somebody is coming out with headache, it can be a young patient, it can be an older group of patient. Always stratify their risk. What are the possibilities that they can have? So somebody who's on a dual drugs like this, so we need to definitely think over not relieving by analgesic. CT need to be taken. So That doesn't mean that all headache that is coming to us who's on ecosprin and warfarin, CT should be advised. It doesn't mean that, because from the history, 10 days history, multiple episode of vomiting, these are all things pointing out towards something. Who is not routinely monitoring his INR therapeutically, whether it is subtherapeutic or we don't know. So those group of patients, definitely we need to take a CT, and you should know the red flags. As we have discussed, what are the red flags for a headache? Young patient, what are the red flags? And elderly age group, what are the red flags that you need to understand? Okay, fine.